Thank you. And of course, I have to say thank you to Georgia for inviting me here to speak. It's a privilege to be here in Athens. I brought my family. They are around the Acropolis, and they were very grateful that I am here because now they can go shopping with their mother. So I'm going to tell you a little bit about our practice and what we've been doing. And this really is a story of 10 or 12 years of asking questions of post-mortem imaging. What can it offer? Does it work? Do parents want it? All these kind of questions, because we, in the same as in Greece, we don't have enough pediatric pathologists to do all the autopsies, and parents do not want an autopsy. So can we offer something else, and does it work? That is the premise of the talk. I have no conflicts of interest. If you get the opportunity to come to Great Ormond Street, it's a beautiful hospital with a combination of old Victorian buildings and some brand new research facilities. And if you didn't know, it was originally set up by Barry, the author of the Peter Pan novels, and we still have the Peter Pan statue outside. There are about 7,500 autopsies that are done in the UK every year, and Great Ormond Street does about 10% of that work. So we see about 600 dead children. I have to warn you that there will be images of dead children in my talk to illustrate some of the points. And roughly we see a quarter are very early fetal and perinatal deaths, a quarter are terminations of pregnancy, a quarter are stillbirths and the neonatal deaths, and then about a quarter are older children, forensic aspects, or teenagers. So about 3/4 of those now undergo cross-sectional post-mortem imaging, and I'll give you some illustrations of what we use differently for what ages and whether it works. So these are some of the questions that I will pose, and come back to these at the end of the talk to see if they make sense. So what is the need? Do we really need any post-mortem imaging at all? I think yes, because parents think it's more acceptable, and we don't have enough pathologists. So what diseases are you looking for? You must use the right imaging for the right disease, and it depends on what age of the baby you're looking for and which country you're in. So if you're practicing in the US and you have a teenager come in, he's much more likely to have been shot or stabbed than in the UK. What imaging modality should you use? And actually many of you are already using X-rays for post-mortem imaging. We'll come to that. And a little bit about minimally invasive autopsy, how imaging can actually guide what you need to target in terms of sampling. And lastly, if we have time, I will show you some micro-CT imaging, very high-resolution imaging of tiny fetuses to show what is possible in the lab setting. So losing a baby is obviously a very traumatic, life-changing event, however it's done, and medical autopsy traditionally can provide useful information in about 30 to 50% of cases, which probably already tells you 50% do probably not need investigating. But parents don't want this. They don't want the baby cut. They don't want a big incision. They in particular don't want the head opened. And they don't understand why it's relevant. They don't know. They think their baby has suffered enough. They're probably right. They don't want their bodies cut up. And they don't really know how it will help them. So there's a whole educational piece that we have to do here, from fetal medicine and obstetrician people to, we have bereavement midwives who help during this point. They have a huge role in educating parents what could help them, how might it go. And historically, it was said that people didn't want this because of religious reasons. Actually, that's not true. Probably about 10% of the refusal is religious, so these are Muslim or Jewish population, but most of the time they are non-religious reasons, like we don't want the baby opened, we don't want the head opened, we think the organs will be removed. And if you remember in the UK in the 1980s, we had a big scandal where organs were found in jars in pathologist laboratories and things like that. But if you ask them why they do want an autopsy, they say, to find out what happened, to understand if it will happen again, this is very important for the next pregnancy, to prevent this from happening to others, so altruistic reasons, helping other people, and to reassure me that it is not my fault. I think we have to understand the significant psychological burden to mothers and fathers who lose a baby. So the percentage of autopsy uptake has been varied over many years, but is usually less than 50%. So if you only offer an autopsy and 50% of people say no, how do you know what the cause of death is in the other 50%? I think we know nothing about them. In the UK, quite a lot of our things, if you look here, if you look at the number of patients who are offered but do not consent, it's around 50%. And offered but fully consent, it's about 50%. But that's for stillbirths. It's much lower in things like neonatal death. So here, people who are offered an autopsy and consent are maybe 25%. So we're sort of providing the wrong service. And we don't know what the right service is, but saying, would you like an autopsy or would you like nothing, probably is not the right questions we are asking of parents. And if you like some data to support that, if we look at stillbirth populations in the UK, this is a big study done by Neil Sabir, a famous pathologist in our department. If you took, I think they took nearly 1,000 stillbirths, 20% could be predicted from the top, from either a clinical history, an ultrasound, an external examination, so you will have a cause of death for about 20%. If you look at the placenta, that accounts for about 20% of deaths, so placental abruption, acute hemorrhages, or infection. And of the other 60%, they're almost all unexplained. So if you autopsy all of those 60%, you will find a cause of death in maybe 1 or 2, but certainly it's not good use of resources to autopsy all of those babies and find nothing. That's not good use for pathologists, that's not good use for the parents, that's not good use of any of our services. And we still have a very high stillbirth rate. Our rate here with the blue arrow is much higher than your rate in Greece with the white arrow. So we struggle with stillbirth rates in the UK, and this is a particular area where autopsy typically does not find the cause of death. We also did a study looking at which organ tells you the cause of death. So this was a big study, again, by the same group. This is 5,000 babies where they asked the question, when you take out the thymus, for example, and it looks normal, how many times did histology of the thymus give you the diagnosis? If you take out the pancreas and it looks normal, in how many times did histology of the pancreas give you the diagnosis? And the answer is almost never. 0.4%. So actually, we have the same data now, but with imaging. So in how many cases where the imaging of the pancreas is normal, in how many cases was histology of the pancreas useful? The answer is 0. So we're now changing the data that we have to support some of the evidence. I know our pathologist is looking at me very carefully when I give some of this data. And you could argue that autopsy has not really changed since some of these images were taken. Does anybody know what the image on the right is from? We had the privilege of going to the art gallery yesterday and having a beautiful tour of the Neo-Impressionism. This is not Neo-Impressionism. This is quite traditional. Does anybody know where the painting is from? Yeah, it's Rembrandt. It's the anatomy lesson of Dr. Tulp. It's from 1632. Many of these doctors paid to be in the painting. But actually, this is pretty much what still happens. You open the baby on the table, open things out, take out the organs. So the approach, the psychological approach, the philosophical approach, hasn't really changed. Okay, so this idea that we can do an autopsy approach by taking all of the history we have, the gestation, we do some external examinations and radiographs, and then we either do a full autopsy or we do nothing. This is now 10 years out of date in my center. And why? So what are the common causes of death? If you, like I say, if you live in Florida and you need to worry about shootings, then you need to have a CT scanner to tell you where all the bullet marks are, where all the shrapnel is. That is not my practice, and again, you must tailor the imaging that you're using for your practice. The common causes of death in the UK are not cancer. They are chromosomal genetic problems, so chromosomal or congenital abnormalities, and then perinatal deaths, so infection, sepsis in particular, placental problems. So those are the things we need to target. Those are the things that we need imaging to pick up. So how many of you are doing babygrams? You report babygrams as part of your everyday practice? No? Okay. So we do lots and lots of these whole body, fetal, skeletal radiographs, image every bone. How many times are they useful? So we can image, we can measure the bones, we can measure the femur, we can give an estimated gestation, but how many times are they actually useful to make a diagnosis? I didn't know either at the beginning, so I thought, okay, I will look at the last 500 we did. In fact, if we look at the last 1,000, of the babygrams, we 700 or so, and actually 90% are normal, and of the 10% that are abnormal, you could have predicted they were required. Because either antenatally there was a skeletal dysplasia, or there was something, maybe the baby had a vactal anomaly, something that said, okay, we should x-ray the baby. So if we stopped doing routine babygrams, we would miss almost no cases. So here is something that actually, it's cheap, it's not very expensive, it doesn't take very long, but we are doing 500 a year. So actually, for somebody to take those images and to report them, actually there is a burden to doing that. Yeah? And actually we're not contributing. So we also, as radiologists to begin with, we're probably doing the wrong investigations. So what about CT scanning? You have a CT scanner, maybe we should put the same baby in the same CT scanner. And post-mortem CT is becoming very popular in adults, but that is because they are doing a femoral injection, they are pushing liters of contrast around the body that will show up then the brain hemorrhages, the stroke, the cardiovascular problems, the coronary arteries, all things that we don't look at in children. They're not going to give you the cause of death in a 2-year-old who was found unexpectedly at home. So what about for things we know that the skeleton is good for? So skeletal dysplasias. Should we be using CT for skeletal dysplasias? Well, not really. It's an expensive way of doing the same thing as an X-ray does. So these are images of osteogenesis imperfecta and thanatophoric dwarfism, but these are easy from X-rays. We don't need a complicated 3D imaging technique just to find these answers. And at the beginning of looking at post-mortem CT in older children, several papers came out saying CT is amazing. You see so many things in dead children. You see the stomach dilated, you see bowel dilatation, you see fluid in the abdomen, all of which are normal. These are normal changes that the pathologist will tell you has no relevance. And then they will say, we can tell the difference between hemorrhage in the lungs, between infection in the lungs. Actually, in blinded studies, you can't tell the difference at all. So these if I just showed you the lung imaging, which I will show you in a minute, you can't make the diagnosis. So we did the first big study of over 100 children from all ages, so not fetuses, not stillbirths, but older children, 1 to 16. And post-mortem CT gave agreement with the autopsy in quite a lot, but that's because the autopsy didn't find anything. So if the CT doesn't find anything and the autopsy doesn't find anything, actually, that's not what we're here to try and do. So in how many cases did CT give the cause of death? About 40%. And when we looked at what CT is good for, it's not very good at the brain, it's not very good at the heart, it's not very good at the chest. The one thing CT is very good for, as you might expect, is for bones, so for fractures. So we routinely now use CT for babies who have died to exclude fractures. So for suspected physical abuse, CT is brilliant. So who can make a diagnosis here? These are post-mortem CT lungs of 6 different children. Which one died of pneumonia? Which one is normal post-mortem change? Which one is drowning? No idea. Yeah? I have no idea, you have no idea, because we can't tell. Yeah? So there are areas where post-mortem CT does not work, it doesn't help, and I'm very open to saying it's very good for this, it's very bad for this. You have to be aware, a bit like when AI comes along, what is it good at, what is it bad at, what do I need to be careful for? CT is very good for gas. So these are examples of gas which has traveled all around the body. This was a girl who was stabbed but then not found for 3 days. So this is putrefaction, decomposition of the body. You can see gas throughout even all of the muscle areas. Can you see the psoas muscle, gas throughout the liver? And CT is really good for fractures. Here, skull fractures. We can do 3D reconstructions with CT that you can't do with X-rays. Accessory sutures, are these accessory sutures or fractures on the X-ray? Can be really, really difficult to tell. These are all actually accessory sutures on the CT and then on the autopsy. And we've written quite a lot of literature about CT for rib fractures. If you take one learning point from today, please do CT in deceased children if you think they have rib fractures. It's amazing, it's much better than this. So in the child on the left who has multiple rib fractures already, you can see those. They probably don't need a CT. And the child on the right who also has multiple rib fractures, but you can't see them, they need a CT scan. And the reason is because CT is much more sensitive to these tiny green stick fractures at the anterolateral portion, which are all related to resuscitation. So anterior chest compression causes this row of resuscitation fractures. But if there is blood around the rib fractures at autopsy, that means that the child had a circulation. So these are not post-mortem, these are perimortem or antemortem. And that's critical for the pathologist. Okay, so we use CT in children in suspected physical abuse, but not for small fetuses. And that's because you get images like this. So here is a baby with gastroschisis. You can see a little bit from the MRI. You can see nothing on the CT. On the right, this is a baby with autosomal recessive polycystic kidney disease. Histology is there, proving it. You can see quite a lot from the MRI in the middle. You can see very little on the CT. So CT is not very good at very small babies, as you would expect, but MRI is much better. And when we did a side-by-side comparison, CT versus MRI, CT is very good in children for fractures. MRI is very good for almost everything else. So let me give you some examples. Here is brain MRI, post-mortem. These are all standard sequences, 1.5T MRI, nothing exciting about the scanner. You put the baby in, do your normal neonatal head scanning. You will get something like this. This is obviously a big subdural hemorrhage with midline shift. This is a physical abuse. The bottom one, this is a child with septo-optic dysplasia and bilateral schizencephaly. If this baby was alive, you don't open the head to make the diagnosis. So if this baby is deceased, do we need to open the head to make the diagnosis? These are the kind of questions you need to ask yourself. And then obviously be aware of developmental changes. So if you do an MRI of a baby at 20 weeks gestation, the corpus callosum may not be developed. So when we started, everybody called that corpus callosum agenesis. But of course it's not, it's just developmental appropriateness. And you have to get used to changes. You lose grey-white matter differentiation. There is a lot of cerebral edema. So often the brains look very tight. That's because that's death. Death is a hypoxic process, and post-mortem brains look like that. You can make some rare diagnoses, things like hemimegalencephaly, and we wrote a nice paper about abnormalities you see on the brain and histological confirmation. So that's really useful. But you can image every organ in the body with post-mortem MRI and make some really nice reconstructions. So this is transposition of the great arteries in a baby of about 30 weeks gestation, was known antenatally. We proved it, just demonstrated it post-mortem. You can see obvious things. This is congenital diaphragmatic hernia in an older child. You can see the mesentery, the bowel, all going up into the chest. What it's really useful for in terms of MRI is 3D of the abdomen. So this is really useful for the pathologist. This is obstructive uropathy. You can see a big, thick bladder, big dilated ureters, big dilated kidneys, and on the other side, a cystic dysplastic kidney. So to know that before you open the body is really useful, because when you open it, everything goes flat. Pathologists, did that go? Pathologists get very worried that they won't be able to do some of the standard things you expect in autopsy, like measuring organs, weighing them. But actually, surely we can do that with imaging these days. We now have semi-automated methods for measuring volumes on imaging. In the next 10 years, AI will be doing this for us automatically. So we can actually measure volumes. We can prove that organ weights and volumes are correlated. So we can do many of those things. And we can actually contribute in areas which are really challenging for pathology. So when there's a stillbirth, sometimes the question is whether the baby was alive and then died, or whether the baby was born dead. And in forensic cases, this is really important. But we can tell usually on imaging, either CT or an MRI, whether the baby has air in the lungs, air in the trachea, air in the stomach, or has no air at all, the one on the right, and has never breathed. So we are using this much more now in the UK. But with all of our imaging techniques, the smaller the baby, the more difficult it is to get good imaging with normal CT and MRI, which is designed for big bodies. So the smaller the fetus is, so below 20 weeks, you struggle. We struggle with CT, and we struggle with 1.5T MRI. We've done some statistics to try and work out below which weight it becomes challenging to make a diagnosis so that we can tell parents. So if they have a baby of 200 grams and they say, can you do a really good brain MRI? You have to say, well, at 1.5T MRI, there is a 70% chance we will be able to get good imaging. So do we need higher field strength? Do we need 3T, 7.4T, 9.4T? Do we need better field strength? Actually, if you compare here left and right, we have 1.5T versus 3T of the body, and then the same of the brain. It's a little bit nicer. It's a little bit clearer resolution, but actually the diagnosis is the same. And then there was a very small study looking at high field MRI. This is 9.4T MRI. Does anyone have access to 9.4T MRI? No. Okay. So in a research setting, you can show what's possible. So here, this baby at 1.5T MRI, you can't really diagnose anything. But at 9.4, you have intraventricular hemorrhage. You have a big congenital diaphragmatic hernia you can see with the liver going up. Actually, you can almost see the layers, the individual layers of the brain. But you all have a modality available to you that you use every day to scan very, very small babies that you're mostly comfortable with doing, and that is ultrasound. Ultrasound is cheap, it's readily available. Many of you already have the experience, either in fetal medicine or in pediatric radiology, and you're really good. We have really nice probes to look at tiny organs in very small babies. So what about post-mortem ultrasound? So these are all images of post-mortem ultrasound from a baby of about 24 weeks. You can scan everywhere really nicely. You can scan normal cranial scan the abdomen, look at the kidneys. You can scan everything. If the baby is very small, there are ways of getting better image resolution. And some of you may know Susie Shelmerdine, who works with me in my center, who's brilliant. She did her PhD in post-mortem ultrasound and developed this technique of a baby in the water bath. So the water makes the connection with the probe. And from that, you can get beautiful images. Here, if you compare ultrasound versus the MRI, 1.5T MRI, so where MRI is limited and ultrasound is really good, I think they're better than the MRI images here. Yeah, you get all of the information from the brain, from the kidneys, from the lungs, and then you can make diagnoses. So these are neural tube defects that you can see very nicely on the ultrasound, also the Chiari-2 malformation that then occurs. This is an atrioventricular septal defect that we can see both on MRI and on ultrasound. And then there is a true corpus callosum agenesis, which you can see. So if you're practiced, if you are good at ultrasound and the requirement is there, actually you can do really well with this. Again, obstructive uropathy, we can see polycystic kidneys. You can do all of these diagnoses with ultrasound. The accuracy rates are slightly lower than MRI, so maybe 75% rather than up into the 85, 90%, but still pretty good. So yeah, if you're skilled in that way and people are asking you to do some post-mortem imaging, ultrasound is maybe the easiest thing to try and do. And what's nice about ultrasound is that it leads you into biopsy. So tissue biopsies we can do ourselves, and the big question with a less invasive autopsy is which imaging do you need to use, and then what tissue, if any, do you need to biopsy it, and how can you biopsy it? So this is maybe the kind of umbrella term that we now use. Less invasive autopsy is everything but is not a full autopsy. So we can either call it non-invasive, where there is no tissue diagnosis, just an imaging, or minimally invasive, where we are either doing tissue sampling or endoscopic challenges. So this is an example of using an endoscope. So they're about the same size as the microphone stand to put into the abdomen. And of course, through the abdomen, you can sample all of the abdominal organs, go in through the diaphragm to sample the heart and the lungs. So you can sample everything through a tiny 1 centimeter incision. So we developed this about 8 or 9 years ago. Now, if you offer this to parents and say, do you want an autopsy? No. Actually, we need to examine the heart and the lungs and the kidneys. Can we do it through a 1 centimeter incision? They say yes. They say, will there be stitches afterwards? No. A 1 centimeter incision, you can use glue just to close like that. So it's very nice. And these are images from the endoscope. And then we tried to develop another technique after that, which we called intact. The baby does not have any incisions because you can put a needle through the umbilicus. So through the umbilicus, past the umbilical vein, just using a small forceps, you can put the needle through, and then using imaging, you can biopsy the liver, the spleen, the kidneys, the heart, and the chest. So this is incision-less, targeted core biopsy through the umbilicus. And then I have to show you some cool pictures from our latest development, which is about micro-CT scanning. Micro-CT is a industrial technique used for scanning rocks in geology and scanning carbon fiber things in Formula One, but gives very, very high resolution imaging of very, very small objects. So we installed one of these in 2016. We actually have 2 machines now, and the difference between this and normal CT is in normal CT, when you lie on the table, it's fixed and the gantry spins. In micro-CT, it's the other way around. So the source, the specimen, the source and the detector are fixed, and you rotate the specimen in the gantry. So I'm hoping the video will play. So here's a bicycle wheel. So the source and the detector are fixed. You can rotate the specimen and then reconstruct the images based on X-ray images as you would do normal CT. And then reformat them in any way that you want, and then change the window and do everything that you normally would. The purpose and why that's important is because if you have a larger baby, you move them further away from the source, you will get the imaging. If you have a tiny, tiny organ, which is only 0.5 of a millimeter, you bring it very close and you will get the magnification. So that utility is really brilliant. We started doing it for hearts. And I know you know Michael Ashworth very well. Michael Ashworth was a cardiac pathologist who recently retired from Great Ormond Street. And when we showed him some of these images of the inside of the heart, he said, okay, I need to retire now because you're doing in 3D what I can only do in one plane. If I cut the heart this way, I can't go back and cut it a different way. Yeah? So we can now do in 3 dimensions in a tiny heart. This is a 20-week fetus. What he can do in one plane. So we can rotate it, we can say, okay, this is the way you need to section to get all of these through. So this is about helping our colleagues do the right thing. But we didn't want to do individual hearts. This is just to give you an example of the kind of resolution you can get, the papillary muscles, the muscles of the ventricles, and then in particular, if you look as we come back at the valve anatomy, you will see the pulmonary and the aortic valve. So here the valve anatomy, can you see the pulmonary and aortic there? That's the aortic valve. So we can make some really nice intracardiac diagnoses using this, but that requires the heart to be taken out. So that's not minimally invasive autopsy. Okay, so what we really wanted to do was whole fetuses. And with some iodine diffuses into the body slowly over a couple of days, but the bodies are very small, so it doesn't take very long. So with some iodine diffuses naturally into the body, we can now get really, really high resolution imaging of whole fetuses. So So this fetus is about 18 weeks gestation. The arch of the aorta is 1 millimeter. And that's an imaging of the brain. We've published some of the diagnoses you can make. So cardiac abnormalities we can now make in situ. Brain abnormalities, obviously, things like holoprosencephaly, we can make the diagnoses, and neural tube defects, we can make those diagnoses very easily. This is actually a mouse embryo to show you how small. If you look at the scale, this is 8 millimeters. So this is less than 1 centimeter. And if you look at the resolution of the cardiac valves just coming in now, in the middle, you see that? So now we can do microscopic anatomy, almost. And there is a big center in the Netherlands, in Amsterdam, run by an anatomist called De Backer, and she has got a fetal atlas from micro-CT of every gestation. So if you want to know what normal should look like at each gestation, there's some really nice stuff. So this is how we would use it in clinical practice. So here's a baby, 16 weeks. Outside, there's nothing to see except for polydactyly. So this is post-axial polydactyly. There are 6 fingers and 6 toes. So that's what you would see on external examination. We have put the baby in iodine for 3 days. So now we can do 3D virtual dissection. So first in the coronal plane, and then you go, oh, the kidneys are cystic. So there are multiple small cysts in the kidneys. If we slow it down a little bit, you can see the normal kidney architecture is there, but there are multiple small cysts. So cystic kidneys and polydactyly makes you think of ciliopathy. So what else do we need to see? So we check the spine, we check that the heart is okay, the spine here is normal, but then we can do axial imaging. So the perineum is normal, there's no anorectal malformation, sacrum is normal, the kidneys are cystic that we said, but then here the aorta, the descending aorta is normal, but look at the pulmonary valve, normal pulmonary trunk. Next to it, that tiny dot, is the aorta. So this is aortic coarctation together with polycystic kidney disease, cystic kidney disease, and the brain is normal here. So now we can make a diagnosis without having to dissect the baby. So cysts in the kidneys, post-axial polydactyly, aortic coarctation, that's Bardet-Biedl syndrome. So now we can test the gene for Bardet-Biedl without having done an autopsy. So obviously I'm choosing some really nice examples to illustrate how it can work, but it's changing our practice. Everybody always says, how small a baby then can you image with micro-CT? So this baby is 50 days as an embryo, so that is 7 weeks gestation. And here, in order to do any histology, you just take slices because there's nothing else, you can't open the baby. So the histology is there, and the 3D virtual reconstruction of the micro-CT as well as the micro-CT plane we can do. This is about the smallest that we can achieve. So for me, post-mortem imaging is really cool. Not only can you get good images that the parents would like to see, and you can make some really nice diagnoses, we can tell them about the diagnostic accuracy, but you can also do some educational work here. So this is a heart that is smaller than 1 centimeter, that actually we took out, we imaged, and then we printed, 3D printed, into something that is the size of something you can hold in your hand. So if you want to explain to parents what transposition means or what truncus arteriosus means, they can't understand on the basis of tiny organs, but they can understand on a color-coded printout. And printing is becoming cheap and easy these days. This bone is a femur from a baby who has severe osteogenesis imperfecta, type 2A. The femur is less than 2 millimeters. How are we going to show the parents a femur less than 2 millimeters of everything? So we printed it out. So the femur is now this big. I have one of these on my wall to show people. But this is now, then you can explain to them, look at the fracture that is across here. The internal bone matrix is abnormal. This is why this baby fractured so easily, and that's what it means for them. If you have a forensic practice, you know I just encouraged you to do post-mortem CT of the ribs. Actually, we are now going on to taking the rib cage out in cases where we think there have been rib fractures, and we now micro-CT the rib cage. It's amazing. Every time you do one more imaging technology with higher resolution, you see more things. And you realize you're probably missing things by using just X-rays. So this was a fracture we thought of the posterior ribs on micro-CT. It's probably a refracture because the bone is expanded. So a fracture through a refracture. And then we find anterior rib fractures really hard. It's very difficult to see on chest X-rays. They're quite difficult to see on CT, but you can see the fracture lines on micro-CT. So we're trying to push the boundaries of what we should be doing. Can we answer some of these questions? But then always I try and bring it back to parents. What do parents dislike and what do parents like? So they don't like autopsy, they don't like cutting things up, they don't like the idea you're storing the organs, and they want to be protective over their baby, all of which I understand. But they do want the information about how the baby died, they do want to help with research, and they do want to help with coping mechanisms. We know that parents who accept some form of autopsy have a better bereavement process than those who accept no form of autopsy. Because those who accept no form often think, what if? What if I would have done this? What if I would have accepted? But those who go through the process of some form of autopsy always say, I'm glad I did that. So now, when we do a parent study and we say, here are all the things on offer, what would you like us to provide for your baby? Almost all of them now, 3/4, will say a less invasive autopsy. Some still want everything, some still want nothing, that's okay. But most now, and this is what our service should be trying to tailor towards. So you remember the diagram I put up before about when we take all the history and external examination and then we offer autopsy or nothing? So now that's finished. This is what we now do. We now offer a post-mortem MRI or the most appropriate imaging. And roughly from that, we will make a diagnosis in 1/3. About 1/3 will need either targeted biopsy or another form of imaging, and 1/3 will still go for full autopsy. But the reason to do this is because we are appealing to the 50% of parents who previously said they wanted nothing. So this is a different population who is coming, who is normally seen by the pathologist. We've published some nice kind of guidelines that you can use about post-mortem imaging by age. So at what age or at what gestation should you consider which type of imaging modality? And we have lots of protocols. If you want a CT protocol or an MRI protocol, what sequences you should use, that's all there. And then to try and justify, if you want to say what service or how to build a service, we've put some quite nice literature together about what the advantages and disadvantages of the different imaging modalities are and what the evidence is now to support them. So is there evidence to support the use of CT? How good is the evidence? So you can now use this to go to your departmental leads and to say. So hopefully we covered some of those things. So what is the need? I hope I've convinced you there is a need, whether it's because we don't have enough pathologists, parents don't want it, or because we have interested radiologists. The diseases you're looking for, you need to tailor the imaging to the disease so that you can maximize detection. And we've talked a little bit about minimally invasive autopsy, and I hope you understand where that kind of fits in to who would need what. Hopefully, I think you have agreed that we have progressed a little bit from the 1630s. We can now offer a little bit more different things. And obviously, I have to thank all of my team. Some of you will know, Michael Ashworth, Neil Sabir. So we have a big multidisciplinary team. These are radiographers, radiologists, mortuary technicians, bereavement midwives, psychologists, pathologists, to everything, to bring everybody together to discuss. That's it from me. If you want to see, there is a very short video on YouTube that we use to explain to parents what imaging might offer. So if you get a chance, just look up miscarriage, Great Ormond Street, or something like that. You'll find it on YouTube. Thank you very much for listening. I'm sure there are questions.
Well, there are some questions in the chatting. Firstly, I would like to thank you for your very illuminating, fascinating, and challenging lecture. And I would like to repeat and underscore that in view of the significant shortage of pediatric pathologists across Europe, which in Greece actually is a virtual absence of specialized fetal perinatal pathologists, PM imaging, post-mortem imaging has emerged as a very, very useful and promising tool in collaboration with the knowledge acquired by pathology over the centuries. So I have a technical question. Does feticide by injection of potassium chloride into the heart affect the quality of post-mortem imaging, because it is known to induce autolysis in the brain? And in anatomy, we often have problem to identify brain lesion when feticide has been conducted this way.
No, essentially it doesn't. So we recognize the side effects. We recognize, we can see the needle track, we can see pericardial effusions, we recognize when it's happened, but no, it doesn't change the imaging. You can still, and of the brain is still intact. It's quite interesting. Even macerated fetuses who may have been dead for 2 to 3 weeks, even if they are then refrigerated for maybe 10 days or so afterwards, we still get some really nice brain imaging where actually the autopsy is almost impossible. So yeah, in the brain in particular seems to be preserved on imaging.
All right.
So yeah.
Thank you.
Thank you, Professor, for being with us today. Actually, I was about to ask you a question about the time span between fetal demise and diagnosis, but especially for delicate diagnosis for brain damages, but you have already answered that.
So it's interesting. So everybody thinks they have to rush to do the post-mortem MRI, like within 24 hours or 48 hours. In our practice, we never made it a rush. And secondly, we wanted to see how good things were. So maybe after 1 week, do you still get good imaging after 2 weeks? So we are a referral center. Our babies die in a peripheral hospital. They maybe are with their parents for 2 days. Then they are refrigerated. Then it's 5 days before they come to us. Then it's 5 days before they are imaged. Actually, we still get really, really nice imaging. So the delay part does not change what we're able to do. The main thing that changes the quality of imaging is maceration. So if the baby has died 2 weeks in utero, then the autolysis process has started, a lot of decomposition has started. So even then, if you rush to do the imaging within 24 hours, still the imaging is poor. But it's better than the autopsy, because the autopsy is almost impossible in tissue that just fragments in a macerated brain, in particular of a tiny baby. So, but those things we can't do anything about. In utero death will occur. Maybe the mother presents 10 days later. We can't change that time period. So we can still do the best we can, and usually people are worried that the imaging will not be very good. You can just counsel them. Maybe the imaging won't be great, but we will still get something.
So how confident you are in your diagnosis, for example, in defects like partial verminogenesis?
Yeah. So there are some things which are really challenging. Actually, mostly what prevents that is post-mortem artifact and some of the post-mortem shift. So if you're looking for subtle brain lesions, that's very hard on all post-mortem imaging. We have a colleague called Stacey Gergen who works in Melbourne. They have a population which are quite consanguineous, and they have many, many brain abnormalities. She always counsels them to have a fetal MRI instead of a post-mortem MRI. And actually, they're much better. So if you can make the diagnosis on fetal MRI whilst the baby is alive, even if they're going for a termination, it's much better than post-mortem MRI. So we know it's not as good, and in specific questions, you can miss those diagnoses.
Thank you.
There are some questions online. When you initially started imaging post-mortem, was it difficult to figure out post-mortem changes? How did you co-work with pathologists?
Yes.
How did you do that?
Yeah, at the beginning, we were reporting all kinds of things that the pathologist would laugh at us. So we said there are big pleural effusions, there's a pericardial effusion, the bowel is dilated, there's fluid in the abdomen, and they're like, yeah, that happens. It's okay. But the stomach is dilated, which some of the times we reported bowel obstruction, because in life, if you see a big dilated bowel, there must be an anorectal anomaly. They go, yeah, that's normal. That's kind of what happens. So we've written a couple of papers to say these are normal post-mortem change. And the first thing that you must do is understand the normal changes so that you don't call normal change pathological. Once you have understood some of the normal changes, then you start to filter through, say, okay, in fact, so the baby's been dead for 24 hours, but has massive pleural effusion. That doesn't make sense. That's not normal post-mortem change. If the baby's been dead for 2 weeks, and then there is a small pleural effusion, okay, that's normal, normal post-mortem change. So it's just appreciating, looking, experience, and we think you need to do between 150 and 200 cases to kind of just get used to what is normal everyday stuff.
And is the duration between the death and post-mortem imaging affecting like the density of tissues on CT and the signal intensities?
Yeah, a little bit, but not as much as you think. So you don't need to change the scanning protocol, for example, from a baby for 1 day versus 2 weeks. You just need to understand that if the signal is slightly different, it's probably related to that, physiological changes after death, not pathology. Yeah. Okay. Maria.
Thank you very much for this excellent presentation.
Do you want the microphone?
Thank you very much for this excellent presentation that opens our fields. I feel that it is the beginning of post-mortem imaging, especially in pediatric radiology. We have a task force at the SPR, which is great. And do you think that our residents should have some training in what is supposed to be normal for post-mortem and abnormal? Just a training, because it's a subspecialty in a way of our specialty.
So who would be a radiology resident these days, huh? You have to train in post-mortem, you have to train in AI, you have to train in some computer science, you have to train in everything. So the training is growing, isn't it? So I think in some centers, maybe the large centers where you start to offer this, they should be exposed to it early in their training. Yeah, I think that would be very useful. But we run educational courses. We have run 2 now international courses dedicated to pediatric post-mortem imaging. One was in Brussels, and then the next one was in Rome. So if there is an appetite and there are people who want to come and learn, we can do a 2-day workshop where you go through everything with hands-on, going through cases, CT, ultrasound, MRI, with the diagnoses, so you become familiar. The main thing to take away from today is it's not as difficult as you think, and you already probably know how to do most of it. Yeah, Georgia.
Thank you, Owen, for this fantastic lecture. I have a practicality question. What about the time slots that you perform all this imaging?
Yep.
Is it out of hours? Is it a separate time slot?
So you just fit it in when you can. We started off doing out of hours. So usually after 7, 8 p.m., we have actually 5 scanners, but usually after 7 or 8 p.m., at least one is empty. So you have an opportunity to scan. The problem you probably have will not be time on the scanner, but will be radiographer time, technician time. Who wants to stay afterwards? Who wants to be paid to stay afterwards? All those things. Actually, we often have 2 scanners for live children running during the day. One has an anesthetic list, and one has children who are sedated. And there are many delays with sedating children, waiting for them to fall asleep. The anesthetic is too heavy, too light. Then they are going to the recovery. So we find 20 minutes, 30 minutes in between, where actually just go to the mortuary, you can pick the baby. If you need to do the head and the abdomen, okay, so 20 minutes, do the head, and take the baby back. Later on in the afternoon or the following morning, there is another 20-minute gap. You can go get the baby, scan the abdomen, 3D T2, isotropic, is fine, done. So actually, there are usually opportunities, but it requires a little bit of thought, a little bit of knowledge as to what's there. The radiographers need to be a little bit, okay, we have this baby, how do we fit them in? And also the radiologist to understand the question. So we have a baby where all the antenatal imaging is normal apart from the chest, and we can't determine whether it's a diaphragmatic hernia or CPAM. Okay, fine. Then you have 20 minutes, one 3D sequence through the chest, finished. Yeah? And then you can look at it afterwards. So focused imaging is really useful. Focused, intelligent radiographers and technicians with radiologists and pathologists who understand what the question is we need to address will make it very smooth.
And the babies are prepared by the pathologists?
So everything is referred to the pathologist. The pathologist is the person who accepts the case. The pathologist is the person who must detail all of the other things, the blood tests, the placenta, all the microbiology, everything that is being done. So imaging is one part. So I think of it like the oncologist. The child goes to the oncologist for treatment of their cancer, their Wilms tumor. We do the imaging. We can help them with that. But the rest, all the chemotherapy, everything else is done by them. We don't need to become radiopathologists. Yeah? Our expertise is in imaging, and we are very good at it. So we should provide the imaging basis to help the pathologists in their journey to make the diagnosis.
Thank you.
Thank you very much. Excellent. Brilliant. I have a question. What about the next 10 years? What is the challenge for the next 10 years? Now we have this, it is unbelievable, but in the next 10 years, what we have to accept?
Yeah. So computerized reporting, we've heard a little bit about AI, but this is going to come into everything. That might help with interpreting normal changes. So actually, if the AI only learns normal changes, that might help quite a lot in post-mortem imaging to help the beginners to understand when something is abnormal versus normal. So the big thing that maybe I did not mention is if you think about the population of childhood death, the number of children who die in the UK is very small, maybe 1,000 across the whole of the UK every year. The number of stillbirths, 5,000. The number of late miscarriages, terminations of pregnancy, 5,000, 10,000. With micro-CT, we are looking at below 20 weeks. So that's miscarriage. The number of miscarriages occur in the UK every year, 100,000. So if we are going to give post-mortem imaging, if we're going to make it available, that is the population we need to think about. Very, very small fetuses, many of whom will be normal, but how do we go about trying to provide the best healthcare for them versus the suspected child abuse child, who you maybe will see 5 in a year. So I think that is the challenge. This will offer something for a different population to who is currently coming to the pathologist. Yeah.
Well, thank you, Professor Arthurs. I'm sure that after your lecture, there will be at least a handful of enthusiastic radiologists ready to become dedicated and in post-mortem imaging and take over in the next year. So next time you come over, we can organize a debate.
A debate? Yeah. We should have the pathologist is against, the radiologist is for? No. No, I'm very happy to stay for questions over lunch, and many of you may have been to Great Ormond Street. You know we offer fellowships, training opportunities. If anybody wants to come to the UK and do training, specifically in post-mortem or other things, our doors are always open. So speak to the people you know, who we know in the SPR, Maria and Georgia, and you're welcome to come and visit. Thank you very much for having me.
Thank you.